The following podcast is part of a certified educational activity titled Many Roads to Myeloma Remission, Making Sequential Choices with BCMA and Non-BCMA Immunotherapies. Access the entire activity and complete the post-test at peerview.com/JGX860. Downloadable slides and practice aids are also available.
Morning, everybody. Welcome to this early morning satellite symposium. It looks like everybody is appropriately caffeinated and fed. We've got a great program for you all today. I'm joined by outstanding colleagues and faculty this morning, and we're really going to talk about many different roads and pathways to get patients to complete remission. And I think sort of the underlying theme here, and we're going to have a couple of nice patient cases to go along with this, but the underlying theme here is that there isn't necessarily one path for every patient that comes out there, and that there may be multiple ways to think about how to induce deep and durable responses. And fortunately, unlike 20 years ago, we have choices and we have options that we didn't really have before. So again, I'm Sagar Lonial from Emory. I'm joined by my colleagues Hans Lee and Karina Patel, and they'll do a little bit of introduction during their talks as well. So our goals for today are to look at these four areas here, focusing on long-term evidence in support of BCMA CAR T cells, BCMA antibody-drug conjugates, BCMA and non-BCMA bispecifics and their role, and newer CAR T constructs, bispecifics, and trispecific antibodies that are emerging in the field as well. I think it's pretty clear that there is significant progress with BCMA and non-BCMA immunotherapy. And when, again, I think back to 20 years ago when we were really sort of arguing about whether we should combine proteasome inhibitors and IMiDs, it was a very different world than today. As of 2021 and 2022, we had the first CAR T cells approved in late lines. In 2022 and 23, we had the first BCMA and GPRC5D bispecifics approved. In 2024, we had earlier lines, both ide-cel and cilta-cel approved. And then in 2025, belamaf was reapproved just very recently, and linvoseltamab was approved both in the U.S. and in Europe. So very rapid progress and translation across this platform. However, despite all of these advantages, what we know from real-world data is that many patients are being retreated with the same agents again when they are both len and dara resistant. And so while we have really great options targeting BCMA and other important novel targets using things like CARs, bispecifics, or antibody-drug conjugates, their uptake has not been as great as one would hope, particularly given the significant improvements in progression-free and overall survival that we've seen with a number of these treatments. So part of the main goal for us today is to really talk about why you should find out ways to implement these strategies so that you can take advantage of this and we can change that PFS and OS curve for patients that are len and dara refractory. Now, I mentioned we were going to talk a little bit about HealthTree and their Cure Hub. There certainly are a number of really exciting and important options that are available through the HealthTree website. And the Cure Hub really is a direct-to-patient approach where you have the potential to upload your data to the cloud, if you will, and allow researchers or yourself to potentially link laboratory studies from different institutions, and it then lives on your, you have access to all of that. And this is really unique. I saw this last night in terms of its execution. And so if you're a patient that sees doctors in 3 different hospitals, this will actually link the data from all 3 of those hospitals so that you can see like data over time. And if you go to another doctor, a 4th place, and they can't have access to all of it, you can actually show it to them on your phone or your tablet or your computer. So these opportunities are really, really exciting. And I think HealthTree is doing a huge service for patients to be able to provide this single source of truth in terms of outcomes. There's also a number of educational opportunities that you'll see at the HealthTree website that's listed down at the bottom. These, I think, are very, very exciting opportunities where patients have access to this kind of educational material in a number of different formats, so patients can figure out what works for them, and we'll use that overall. And finally, or not finally, but another unique portion of the HealthTree app is that many of you in this room are presenting data at ASH. If you go to this QR code, you have the opportunity to record, and it'll go on the HealthTree ASH summary. And so you'll have the ability to share your important information with patients and other docs around the world through HealthTree as a central clearinghouse, if you will. Again, there are a number of ways both patients and researchers can connect through the HealthTree data set. You can see some of that listed here. Connection to cures, coaching, connect, volunteer, as well as a number of ways to make sure that underrepresented minorities have access to cutting-edge therapies and support group as well. So we'll start off with an example of what I think HealthTree has done really quite well, which is correlating patients who have gone through different treatments. This is a patient who had a CAR-T, and we're going to hear from Lisa in a short video about her experience with a CAR-T.
Hi, I'm Lisa. I really appreciate the chance to share my perspective as a high-risk multiple myeloma patient who relapsed early and went on to receive CAR-T therapy. My hope is to give you a window into the patient side of this journey and remind you how important your partnership matters to patients like me. I didn't present with typical symptoms. I wasn't anemic. My calcium, kidney function, and proteins were normal. My back pain just was there and kept getting a little worse. And so it took many, many months of pushing for answers while being told that my symptoms were likely caused by playing tennis too hard or my age. And eventually a spine specialist sent me to an oncologist, and we had more tests. And in October of 2023, I finally had a diagnosis. So I quickly asked, pretty directly as I can do, if I could pivot to CAR-T instead of stem cell transplant. After a lot of conversation, we decided together that CAR-T was indeed the best option for me, and we moved forward. And today I am so thankful because I remain in complete remission now 9 months later, and I'm deeply grateful that CAR-T was an option. So when thinking about the CAR-T decision, it's a big one for anybody. And as patients are considering their options, my advice would be this. Be informed about your treatment options and your specific disease. Bring your questions to every doctor visit and make sure that your care team understands not just your disease, but your quality of life goals and your life circumstances. And that partnership and conversation can make all the difference. One of my most trusted resources quickly became the HealthTree Foundation. HealthTree has amazing educational resources. Even though I had, as a patient, a really strong caregiver in my spouse, I had very good friends that supported me along the journey and a wonderful care team. Having others who have gone through this journey of CAR-T and other things associated with myeloma was really helpful. And so HealthTree gave me a single place that allowed me to learn very quickly and actively engage how I wanted to as a patient. For the healthcare team, boy, I would encourage you to direct your patients to trusted resources so that they can be informed and be active participants in their myeloma journey. Understanding the CAR-T journey for me was critical in order to make what I felt was a good decision in partnership with my care team that made sense at that time with what we knew for me. And being in remission still 9 months later, boy, it's worth it for me. So I appreciate the opportunity to share my perspective as a patient as we continue this CAR-T journey and opportunity for others to benefit like I have. Thank you.
All right, that was great. And I'm going to introduce Dr. Patel now, who's going to come to us talking about CAR T-cell. Dr. Patel is from MD Anderson in Houston, Texas. Karina?
Fantastic. Thank you, everybody, for coming this morning and to the organizers of PeerView for inviting me. I get to talk about my favorite topic, which our patient just showed you. The magic of CAR-T for our patients really is that not just high-risk patients, but standard-risk patients, these are some of the best responses we've seen. And the fact that patients have a one and done and kind of feel back to normal is pretty amazing, and why I get really excited in clinic when I see my CAR-T patients. Okay, so we have two cases, and I'm going to get some information from my colleagues who, might be a little bit more on the bispecific or ADC side of things, but just to kind of get an idea of who are these patients now that CAR-T is available both in late line and early line, based on toxicities, the logistics. How do we decide who gets CAR-T when? And so there's two patients here. So Alex has standard risk myeloma, 59 years old. Treatment history of a quad with auto transplant, Len maintenance, and current status is that after 2 years, it's having a clinical relapse with symptoms plus M protein going up. And then Amy has triple class refractory myeloma, 69 years old, and treatment history has had 4 lines of therapy. So again, had a quad, transplant, Len maintenance. Second line got KRD. Third line got ACPE, and then fourth line got selinexor dexamethasone, and now has confirmed progression with the PSF2, and both are BCMA naive. So based on this, I wanted to ask my colleagues, would you consider CAR-T therapy for either one of these patients, more for one versus the other? Thoughts, Hans?
Yeah, so answer is yes to both.
Good answer.
And I think, just to comment on the first case, this patient got quad therapy induction and then relapsed 2 years thereafter. And so this patient is functional high risk. So even though the patient had standard risk disease on paper at initial diagnosis, and there's really nice updated data from Luciano Caso defining really functional high risk in the era of quads, this patient would be a clear candidate for CAR-T therapy.
Awesome. And then, both of them have active clinical symptoms, right? So this becomes a logistical thing of, do you have a preferred holding therapy? Like, do you want someone to get treatment but while you're working them up for CAR-T, waiting for that, insurance approval, apheresis? Is there something specific that you would or wouldn't do for those patients?
Yeah, I think it really does. These two cases really highlight the challenge of later line CAR-T cells, which is your options are a lot more limited. I think in the case on the right, the fourth line progressor, there had been early on a hesitancy to use a bispecific in that context because of concerns on impacting the potential CAR-T cell quality. But I think there's a lot of really good data now, for instance, with talquetamab bridging. One of my longest responders actually on cilta-cel got teclistamab as bridging when we didn't have other great options. So I think you use the best available therapy. The answer for the patient on the left is a whole lot easier.
Exactly.
And there I would think about something that I can give short that will get a deep response, because this is not a 3 or 4 month bridging. This is probably a 1 to 2 month bridging while you're waiting for CAR production.
Yeah, no, fantastic. And yeah, I think withholding therapy before apheresis, it's things that we want to make sure we don't affect your T cells. So alkylators, things like bendamustine, we really don't want that right before. After apheresis, we have a lot more options, including the bispecifics, et cetera. And some of our patients in late line, for instance, we've had talquetamab when somebody already used it because they wanted not to use BCMA. As long as they come in pretty early after they've started, we can still collect their T cells and manufacture. It's when people are on T cell engagers for a long period of time, usually 6 months a year. We don't know the magic number, but the more they're on it, that's when those T cells become exhausted, and then we see a decrease in that manufacturing ability and out of spec rates, and maybe the clinical efficacy is not as great. So anything to make sure our patients are doing well. And then in terms of, we talked a little bit about this, but what about addressing short-term and long-term safety considerations? Anything you do for infection risk? Obviously, we're going to talk a lot about infections with the bispecifics as well, but Hans, anything specific you make sure you do for these patients?
Yeah, absolutely. In the early, first 30 days post-CAR-T, we often see cytopenia, so just watching for neutropenia. These patients may need infection prophylaxis with antibacterial prophylaxis if they're neutropenic. But long-term, recommend antiviral prophylaxis and PGB prophylaxis for at least a year. And then also considering IVIG if the patients are hypogammaglobulinemic.
Yeah, perfect.
Yeah, and I do think it's important to sort of reemphasize some of the interactions with the public discussions.
Yes.
You know, at least in my state, a lot of people like to go to Georgia football games. And I tell folks that are in the midst of this, that's probably not a great idea. In this state, I don't think anybody's going to Florida football games anymore, but at least in Georgia, that is a big deal, and Alabama. And so I think those kinds of sort of social interactions, I think, are important.
Limited. Yeah, the first 3 to 6 months is when I tell people just hunker down a little bit. I give IVIG every month. But then after that, they actually do so much better because, again, they're not on treatment. Their immune systems are coming back. And so we can stop a lot of the infection prophylaxis again 6 months to a year later, which that's when I tell them to travel to Japan, go do all the things that they want to do. So, the first 3-6 months, we're a little bit more careful. Okay, so with that, going into a little bit of the data, again, in the NCCN right now, we have CAR-Ts available in early line. So 1 prior line, including an IMiD, a PI, and refractory to Len for cilta-cel, and then 2 prior lines for an IMiD, PI, and anti-CD38 for ide-cel. And again, there are other recommended category 1 now with belantamab, which we'll talk about with bortezomib dex after 2 prior lines. So lots of BCMA moving up. So talking about, sequencing is going to be big. And then again, the big data from CARTITUDE-4, which, showed some of the best responses we've seen in terms of a phase 3 CAR-T, so cilta-cel versus standard of care of DPD or DVD, hazard ratio of 0.26, PFS not reached, and then, higher rates of MRD negativity as well. And then there's also other data that shows if you're early line, your response is better. The question always came up that if late line patients did so well with CAR-T, then why wait? Or why do it early because of the toxicity? But you see here 1 to 3 prior lines, 30-month PFS is 80%, versus if you're greater than 3 prior lines on this study was 59.9%. And there's an updated abstract on Saturday about this. So again, standard risk versus high risk, there is a difference, but it's still much better than the standard of care, and early line is still much better than late line for those patients. The other big thing is bridging therapy. So as we talked a little bit about with those cases, the better bridging we have, the better options we have, the better it is for our teams, but it's also more likely that our patients are going to have responses to that bridging coming into CAR-T. Some people will say, well, that's just because that myeloma is sensitive. Sure. But now we have talquetamab in late line, which I'll go over some of that data. So we can make myeloma can be sensitive to newer therapies as well. And we know from lots of data, not just the cilta-cel data, that those patients that have better response going in have better efficacy, but not only efficacy, their risk of toxicity drops significantly, especially those serious toxicities that we worry about, like delayed Parkinson's and cranial nerve palsies. And so here, again, late line patients. So in the US, talquetamab is approved after 4th line, so I can't use it for bridging early line anyway. But in late line patients where most patients are penta-exposed or refractory, it has actually been a great way to knock that myeloma down before coming in. And a lot of our patients, even with just the step-up dosing, if they have light chain only disease, you'll just see this amazing response after that first couple weeks. So safety-wise, we did not see any extra CNS or CRS or ICANS, and we definitely didn't see any delayed neurotoxicities or other long-term toxicities, increased risk, which was great. And again, our response rates over time have improved, and I think we'll see PFS hopefully soon. But feasibility-wise, it's been fantastic to use in our late-line patients. And then again, long-term outcomes from KarMMa-3, which is the other phase 3 for ide-cel in earlier line, show that older patients versus younger patients, you actually saw some really great response rates even in our older patients. So those who are greater than 70 years old, overall response rate of 81.6%, median PFS 18.9. And the biggest thing here is to take away also is the overall survival. So when you see patients on CAR-T studies, those overall survivals are so much better. And again, when we talk about sequencing, that's what I want to look at, is what happens to overall survival of patients who got CAR-T first, followed by bispecifics, versus the other way around. And you'll see the overall survival ends up being longer for patients who got CAR-T first. And so again, in late relapse, we have, of course, CARTITUDE-1 and KarMMa-2 with ide-cel and cilta-cel already approved. But now we have bispecifics as well. So what happens to that patient that comes late line? And I think, we have belantamab as well in certain circumstances. So again, we have a lot more options. And I think what most of us will say is that if a patient is eligible for CAR-T, we want them to get that first because of all the T-cell health and manufacturing and bridging and all those things that really matter, and that one and done. that time off therapy you're going to maximize by going earlier, especially for our high-risk patients, but including our standard risk patients. And so really important to, discuss this with our patients. And one of the more scary statistics is that out of all the patients in the U.S. that are eligible for CAR-T, it's about 10 to 20% that actually get CAR-T. So, something that we really need to think about and make sure our patients have access. And again, the one functional cure in relapse refractory myeloma we have is from the cilta-cel data. Again, it's 33% of patients, so it's not as high as I want it to be, but hopefully when we get the early line data from CARTITUDE-4, I'm hoping it'll be higher in terms of that plateau. I still don't tell all my patients that they're cured. I still tell them I need to watch them because I do think their myeloma eventually will come back. But to get 5 years of no treatment when you had 6 lines of therapy is a really big deal for our patients. So I think really, really important data that we now improve on. And again, MRD is really important in some of these patients where MRD undetectable still. And then there's also real world data. So we had cilta-cel patients who got cilta-cel, and looking at those who had prior BCMA therapy versus not. And again, you see those who did not have prior BCMA therapy have a much better PFS than those who didn't, and especially 6 months. Again, was it a bispecific? Was it a CAR-T? Was it an ADC? All those things matter in terms of resistant mechanisms. But when you combine them all together, as long as it was 6 months or higher, you actually got a better response. So we'd still try to do CAR-T first if possible. And then again, safety-wise, in terms of prognostic factors for older patients, again, patients do really well even in older settings. Okay, so then the unique toxicities, sort of going through the CRS, ICANS, infections, cytopenias, most of us are able to deal with that for all of our heme patients. The delayed neurotoxicity, again, improved for patients in early lines. So it was 0.5% in CARTITUDE-4 versus the 6% in CARTITUDE-1. So we know less myeloma helps improve that. But something that we're seeing now in the real world that was not seen on studies is immune effector cell enterocolitis. Again, most of us are learning this. The CAR-Ts do cause actual colitis. And now that we're figuring it out and diagnosing it earlier, we actually can intervene and reverse it. But earlier, maybe just even a year ago, the mortality from this was 40%. It's 1 to 2% of patients that are getting this, but still something very important that we do talk to our patients about, and something, again, that we're learning about and diagnosing and intervening much earlier. So with that, again, the biggest things that we need as CAR-T centers, adequate planning and referral. So if you can send patients 1 line earlier than they're due, that helps us quite a bit. Early line, again, we have so many options of bridging. We discuss with everybody, the community teams. Patients can go back home while their CAR-Ts are being made. It takes about 4 or 6 weeks. And we have them come back when we know their disease is improving. So patients where it is improving, we go to CAR-T right away as soon as their cells are there. But when it's not, if they're improving, but I think they could do better, we could either continue that bridging, so we don't have to give the cells right when they're ready, or I can even switch bridging. So again, the more options I have, the better outcomes our patients have down the road, and the earlier they come, the easier it is to do that. And then the infection management and long-term follow-up are really big. So we send letters out to all our patients and their teams to say, these are the things to look out for. Here's my number. Call me if any of this is happening, so we can help make sure, for instance, diarrhea, that's really significant, that we can get those patients back in and reverse any significant side effects. All right, so with that, coming back to our patients, again, 59 years old, Alex, she gets holding therapy, decides to go to CAR-T, gets holding therapy, that's DKD. So again, no alkylators or T-cell detrimental drugs. And then bridging therapy, we actually still can use PI, IMiDs, and anti-CD38s because, again, that patient doesn't have a lot of exposures to therapies. Versus Amy, that's heavily pretreated, is a little bit older, but again, we try to not mess up the T cells, but we can actually use talquetamab in this patient for bridging. And again, most of our patients have done really well when using talquetamab. All right, so then my last couple of minutes, I'll talk about what's next with CAR-T. So a lot of this data is being presented at ASH this year. So faster manufacturing, targeting multiple antigens, and in vivo cell engineering. So on Saturday, there'll be a presentation, but there's another BCMA CAR-T, anito-cel, that uses a little bit different domain, D-domain binder, but has rapid, reliable manufacturing with less than 17-day turnaround time and 96% manufacturing success rate. And their phase 1 study, this is the phase 2 study, Imagine-1, that we'll be presenting on Saturday. Again, the data from EHA is 97% overall response rate, 68% stringent CR. and a 78% 10 to the minus 6 MRD negative rate. So pretty impressive, and mostly grade 1 CRS, if anything, no grade 3 or higher, or only one patient had anything grade 3 or higher in terms of ICANS or CRS, and the 18-month PFS rates of 66% so far. So we'll have an update on that data. There's another great CAR-T that's being presented around that time, Durga-1, which is the CD19 plus BCMA, so one of our first dual antigen CAR-Ts. And the idea is that BCMA is on our more mature plasma cells and myeloma cells, but maybe CD19 on the myeloma progenitor. We can argue about that for a long time. But so far, their first patients, I think it was 25 patients in the US, 100% response rate. And again, MRD 100% for those who are evaluable at 10 to the minus 5th. Their CRS rate 64%. So again, it's a little bit more like our bispecifics, even in the CRS. And again, both of these have not had any neurotoxicities delayed or colitis, which has been fantastic as well. And then the last study that I think is more of a science fiction project, and it's really cool. I'm waiting for more long-term follow-up, but this is one of the late-breaking abstracts that will be presented on Tuesday. An off-the-shelf in vivo CAR T cell. So basically, you just get the lentivirus or the vector. I think it was lentivirus for this one. There's a few of these, but you get that injected. It goes to your T cells in vivo and actually creates your CAR Ts, which is really, really cool. So you don't need to manufacture outside the body. I have a lot of questions, but again, three patients that they had amazing responses for, and a lot of cool science that I'm sure will be presented on Tuesday. So exciting times to, again, increase hopefully access to patients and decrease toxicity based on what we have already. And a couple other things, GPRC5D, again, we have a bispecific already, but now there's CAR-Ts. And again, great response rates for Arlo-cel that have been presented before. And this is the phase 1 data and in patients that have prior BCMA therapy. So again, a lot of stuff happening at ASH that I'm excited about. Then Dr. Loniol, it is your turn. Thank you.
All right. Well, thank you very much, Dr. Patel. A great opportunity to hear some of that data. Well, I'm going to spend the next few moments talking a little bit about BCMA antibody-drug conjugates in the context of relapsed refractory myeloma. And while we were very excited to have this option several years ago, it was briefly taken away, and we were, again, very excited even more recently to have it come back as part of a combinatorial concept in the early relapse setting. So I'm going to talk about some of that data. Let's start off with a patient with myeloma and early relapse who's unable to access CAR-T. This is a 72-year-old gentleman whose first-line therapy included Dara-VRD, induction, consolidation, had transplant and single-agent lenalidomide, had a VGPR but relapsed, then got second-line therapy with Pom-Dara. Now demonstrating evidence of progression after second-line Pom-Dara, unable to access CAR or uninterested in CAR. And certainly, again, I think this speaks to the idea that there are many paths to get to deep responses and durable responses. And what I think you're going to hear from all three of us is that there are different options based on what a patient's journey looks like or where they live or what their opportunities are as well. Performance status was 2 and no known corneal disease at the time of visit. So I'm going to turn to my colleagues here. Given the challenges with CAR-T access for this patient, would belamaf, VD, or PD potentially be something that you all would think about?
Yeah, absolutely. And this patient clearly needs a BCMA targeted therapy. And the patient's IMiD refractory, the patient's CD3 refractory, is bortezomib exposed but not refractory. So I think Bela, bortezomib, dexamethasone is a great option in this context.
And let's talk a little bit about integration into practice. I know, Hans, you're going to tell us a lot about how we do bispecifics in routine practice. You talked a lot about CARs. The integration of Bela in the context of a busy community practice or busy myeloma practice. Talk about how you guys have done that.
Yeah, I will say, I think Bela is a great drug, and it's actually easier. It's less high maintenance than our CAR-Ts or our bispecifics, I will say. And again, when we can do dosing spread out, it's actually easier for our patients. They get it every couple months even, right, or every 3 months. So the main thing is making sure the eye symptoms that we talk about and having an ophthalmologist, optometrist on standby to make sure they can monitor that with you. But that's actually become pretty routine for us that our patients can do that quickly. Again, it's less often. So they're able to get through that without any too much pain.
Yeah, it's very interesting because I think there's almost more anxiety on our side than there is on the ophthalmologist side. My neighbor's an ophthalmologist, and I said, yeah, we've got this great new drug, but this is a side effect. And he looked at me and goes, you just deal with the cancer. We'll take care of everything else. So, I think we need to just get sort of over a little hurdle in terms of how we anticipate this, how we manage this, and how we deal with it. And at least for the third point, and I'll start off and let you all react. What I like about the potential for combinations, first of all, I'm a combination guy, so I think we should always be putting our drugs together. But second, I think it allows you to spread the dosing out and take advantage of mechanisms of synergy that you don't necessarily get with single agent therapy. At least that's my view. It looks like my colleagues are agreeing, which is always good. All right, so let's talk about mechanisms of action. We know that there's the antibody drug conjugate where you get the payload effect in terms of into the cell. But belamaf also has the ability to induce effector immune cells as well. So you get ADCC and ADCP, which to me is why combinations with drugs that enhance that, particularly the cell mods and the IMiD class, is so interesting and exciting. And you also get immunogenic cell death as well. So multiple potential mechanisms of action here. And again, in October of 2025, the FDA approved the combination of Bela with bortezomib dex for patients who've received 2 prior lines of therapy based on the DREAMM-7 study, which I'm going to show you as well. So I think this off-the-shelf option with infrequent dosing schedules, and I think Karina alluded to that as well, really does have the opportunity to be very patient-friendly overall. So the current guidelines in terms of what we have available, you can see in terms of preferred and other recommended after 2 prior lines of therapy, including an IMiD and a PI. Bela in combination with bortezomib and dex is a Category 1 recommendation based on the DREAMM-7 study. So here is the DREAMM-7 study, and this is really focusing on overall survival. So we're going to talk about the PFS data in just a moment, but there are certainly emerging studies that demonstrate significant improvements in overall survival. And what you see here is an improvement head-to-head with Bela bortezomib dex versus Dara bortezomib dex, so the CASTOR study. And the PFS in that actually mimicked what one would expect from the CASTOR study, and the OS did as well. So it's not like the control arm underperformed. I think the control arm performed about as you'd expect, and we got significant improvement both in overall survival and progression-free survival. And if you begin to look at numbers like greater than CR, it's basically double. For the Bela arm, overall response rate was quite good. And then if you look at overall survival at both 36 and 24 months, significant improvement as well. What I think is an area that often gets discussed is, yeah, great, you're going to get a great response now, but what happens later? Are you impacting subsequent therapy? And that's where the PFS2 data, I think, is really so critical here. And it demonstrates that there's no reduction in PFS2 if you were in the Bela arm. And in fact, our group, and I'm sure my colleagues would agree with me, have always said, use good drugs when you can. Because if you keep saying, I'm going to save them for later and later and later, you may never get to them, which I think is unfortunate from a patient perspective. And you don't necessarily reduce the efficacy of subsequent therapy if you give good therapy. And as you know, in myeloma, we just keep coming up with new drugs. So just because you got a really good drug early doesn't mean we're not going to have another really good drug later on when the patient needs it. And the longer you can delay that, ultimately, the better it's going to turn out in general. Now, the DREAMM-8 study was another randomized phase 3 trial that demonstrated significant benefit. This is Bela in combination with pomalidomide and dexamethasone. Median PFS almost mimicked what we saw with DREAMM-7, roughly 34 to 36 months for both of them. So 3-year median PFS. And again, the dosing frequency of every 8 to 12 weeks, depending upon which trial you were on or how patients reacted in terms of ocular adverse events. And the MRD negativity rate, the CR rate, all of those things clearly favored the Bela option in partnership with pomalidomide and dexamethasone. And this is being updated on Saturday as well. So let's talk a little bit about the safety and delivery of care. We alluded to that in our discussion right before we started here. But given that ocular adverse events are a relatively new thing for us, I think it does bear merit for us to spend just a few moments talking about that. So there was an assessment of ocular toxicity in Bela-related or Bela-based regimens that included about 392 patients treated in DREAM-7 and DREAM-8. And what we did was actually aggregate all of those events together, look at each ocular exam as a single event, and then put all of those together in an amalgamated assessment. And if you look to the right, what I want you to really appreciate is that roughly 62% of all ocular events were actually thought to be not clinically meaningful, meaning the changes in visual acuity were less than 20/50. So while there were ocular events that occurred, a majority of them were actually not clinically significant. Patients may have transient changes in vision, but at least a majority, they're not long-lived, they're not long-lasting, and they don't necessarily impact quality of life. And we certainly have a Bela maintenance study that we presented at IMS just a few months ago. And in that, I have several patients that have commented to me, yes, for a couple of days, maybe it's a little bit difficult for me to read the paper, but outside of that, my quality of life is actually quite good. And I think the other important take-home from this slide is the fact that of patients with grade 2 ocular events, most of them actually did not have significant changes in function or ocular or visual changes of significance as well. This is really important because the grading scale is more dependent on an ophthalmologic exam as opposed to a clinical discussion on what has happened to your vision. If you look at dose modifications of belamaf, they did not impact efficacy. And this is something that we saw with single-agent Bela from the DREAM-2 study, that the longer you held, it didn't necessarily reduce or cause progression. This, again, is a novel concept for us in oncology, where we're worried that if you miss doses, patients are going to progress. But the half-life of Bela is such that that was, in fact, not the case. And, in fact, most patients actually had deepening of their response or stability of their response during the necessary dose holds because of any ocular adverse events. And so this, to me, is both reassuring from the physician side, and it gives me the opportunity to reassure patients that holding the dose is okay. It's okay to miss a few what you think are scheduled doses, because ultimately patients are going to end up being dosed every 8 to every 12 weeks once you get past sort of the induction phase, if you will. Now, here are the dosing guidelines based on ocular events with belamaf. And again, there is an updated poster on Saturday that's going to talk about standard assessment guided dose modifications. This is actually trying to get away from all of those frequent ophthalmology visits and use things like a Snellen eye chart in your clinic, as well as patients' description of symptoms to drive whether you dose or don't dose, and whether you dose reduce or whether you stay at the same dose. And this is being validated in a number of large randomized phase 3 trials as well. So more to come on trying to reduce the frequency of eye doctor visits as well. And again, if you look at patients that had more than one extended delay, meaning greater than 12 weeks in both DREAM-7 and DREAM-8, their progression-free survival was not negatively impacted in those trials. So again, I think that's a really important evidence-based approach that you can use to both reassure patients, and as a physician, you can use to feel like you know what's going on. So here are the recommended patient monitoring and dosing principles with Bela-containing regimens. Before cycle 1, they need to see an eye specialist for a baseline ocular evaluation. Cycles 2 through 4, they see an eye evaluation before each dose. And then cycle 5+, use the KVA scale to inform whether dose modification is subsequently necessary. And ultimately, it's often up to us as the treating physician to interpret that Latin that the eye doctors send us and what it means in terms of what a patient is ultimately experiencing, and make the appropriate dose adjustments or dose modifications. And again, I think DREAM-9 is a study that is actually attempting to move BCMA antibody drug conjugates into earlier lines of therapy. This is looking at newly diagnosed transplant-ineligible myeloma, combining belamaf with bortezomib, lenalidomide, and dexamethasone, or Bela-VRD. You can see in the early cohorts, the response rate was about 100%, and in the 1.4 given every 6 to 8 weeks, about 91% of patients achieved a complete remission. It's a little early for us to have the MRD outcomes, but certainly about 73% of patients with CR were MRD negative in this analysis. So very early encouraging data, and keep your eyes out for a randomized phase 3 trial evaluating Bela-VRD versus Dara-VRD. That's likely coming very soon. So keep your eyes out for that randomized phase 3 trial. And there is a randomized phase 3 trial called DREAM-10, which is looking at Bela-RD versus DRD. So going head-to-head with Maya, which we know has really been transformative in terms of a treatment regimen for older, frailer patients. I think the question is, can Bela do as well, if not better? Certainly, potentially with less frequent dosing, it would be a potential win for patients as well. So let's summarize the patient that we talked about earlier, Dan, the 72-year-old who didn't necessarily have access or didn't want to go on a CAR-T. Dan is len refractory and also CD38 exposed. Guidelines from DREAM-7 and DREAM-8 trials support consideration of Bela-bortezomib dex after 2 prior lines of therapy. Bela combinations certainly are a little bit more convenient with the less frequent dosing. Every 8 to 12 weeks can be used to help manage and mitigate overall ocular adverse events. All right, so we're going to hear from Teresa about one patient's experience with bispecifics.
Hi, my name is Teresa. I was diagnosed with multiple myeloma in 2017 in July. I think everybody remembers the exact day. I was diagnosed from the simple rib fracture when I leaned over in my car to pick up something off the floorboard, and I put my rib cage on the console and my ribs broke. And I'm like, wow, what kind of a non-trauma fracture is that? And that happened in like February, and I kind of lived with it thinking it would go away on its own. So I called my best friend, and he came down and sat with me, and even I went in at 3 o'clock in the afternoon, left work and everything, and by 9 o'clock that night I had my diagnosis of multiple myeloma. So when I was on this treatment treadmill, I started asking the physician, may I please, get on one of these studies for the bispecific antibodies? I didn't feel I was a candidate for the CAR-T therapies because it required too much in the way of caregivers and people around you. I got in, and I did the 6 days in the hospitals for the step-up dosing. I got fortunate enough not to suffer any of the ICANS or the CRS, and I'm still on the bispecific antibody today. I go back to gardening, I've gone back to doing my yard, I've gone back to my hobbies. It's really nice to be able to not have to think and take a pill every day and be off of that treatment treadmill. I would advise folks who have been in many more treatments than what I happen to have been in to definitely consider the bispecific antibodies. It has been transforming for me to be able to just get a life back. The Health Tree Foundation is a wonderful source of information from the beginning of a journey to people who are near the end, even from what in the world is it to how can I make my palliative care go better? It has every stage, which I think is great, and you can focus on whatever stage. It's all said in nice layman's terms so that a science person with a science background of high school will definitely understand it. My mantra has always been live into the cure. It's something I saw somewhere, and I am going to do whatever it takes because multiple myeloma is nearing a cure. I will always be grateful that I was allowed to participate in a bispecific clinical trial and be able to live in a time when this is available. Somebody once said to me, this is a cancer to have. This is a good cancer to have because you have so many treatments. And at the time I thought, oh, there's no such thing as a good cancer. Well, 8 years later, this is a less bad cancer to have because you can be treated. And it does. People live long times with this now. And I'm going to be one of them. I'm going to be one of them.
All right. Thank you. And with that great testimonial, we'll have Dr. Lee come up, who used to be at MD Anderson and is now in Nashville. They have decent football there, too, actually. Yes. At Sarah Cannon. Dr. Lee is going to talk to us about sequencing bispecifics.
Great. Thanks, Sagar, for that introduction. And I'm going to take us home for the next 25 to 30 minutes talking about how we incorporate bispecific T-cell antibodies in relapsed refractory multiple myeloma, and also talk specifically about how we operationalize actually administering these agents in our practices. So I'm going to start out with a couple patient cases like we've done in the previous sessions. So first we have Anne, who has high-risk triple-class refractory myeloma. She's 73 years of age. She has had treatment with 4 prior lines of therapy, DARE, VRD, followed by auto transplant, followed by len maintenance. Second line, carfilzomib, lenalidomide, dexamethasone. Third line, isatuximab, pomalidomide, and dexamethasone. And fourth line, selinexor and dexamethasone. Now she has rapidly progressing disease. She's had no prior exposure to a BCMA targeted agent and worsening performance status. And on the right, we have Tom, who has heavily pretreated myeloma. He's a little bit older, 78 years of age, treated in a very similar fashion to Anne, except at fourth line therapy, had a standard of care BCMA CAR T therapy, unfortunately had a very short duration response of approximately 6 months, and now presents with rapidly progressing disease. So I'll turn to my colleagues for some input here. And so maybe, Karina, if you could comment on Anne's case, what would your thoughts be in terms of the next potential treatment option?
Yeah, I think the fact that she has worsening functional status right now and disease probably related, that you need something off the shelf quickly. And here, again, I think most people say, oh, BCMA therapy, which probably is the right answer. But I think also now that we have GPRC5D bispecifics, that if Anne was somebody that wanted a CAR T down the road, we could actually start with talc first, right? And then move forward down the road to BCMA CARs if she wanted. But yeah, I think she needs something right away. So I wouldn't wait for a CAR T.
Sounds good. And maybe sorry, comment on the second case, patient progressing after a BCMA CAR T after short duration response.
Yeah, I mean, I think if they're progressing after a CAR, the likelihood of a mutation or something functional on BCMA is higher. And so I think the idea of switch therapy with a different target makes a lot of sense. But I will put in a plug that I think there are a number of us now that are beginning to look at sequencing BCMA. And before I think about retreating a patient with a BCMA, even if they've had it remotely, I'm actually starting to do that more and more to understand whether there are mutations there that might impact efficacy.
Great. And I think, there's different BCMA bispecific T-cell antibody options out there. We actually have 3 in our FDA approved. I guess, Karina, can you comment a little bit about, are there any differences and considerations based on efficacy, safety, or even how the step-up dosing schedule is administered of what make you choose one versus another?
Yeah, I think the efficacy for most of these have been pretty similar, which is great that they all work really well. So then it comes down to safety and logistics, right? So whatever's easiest for my patient. So either sub-Q, just because it's a shot, they don't need an IV, or if they don't need it as often and they don't need to be in the hospital. So I think those are all major, we talk about all of those of all the different bispecifics that are available, and that's how we pick for our patients.
Great. And then I'm curious, when you actually administer the bispecific T-cell antibody with a step-up dosing, I think there's a lot of different options of how we operationalize. I'm curious, Sagar, at your institution, how do you actually mitigate potentially that risk for CRS? Or are you doing something different in terms of step-up dosing at your institution?
Yeah, so for about 80% of our patients, they're all getting outpatient step-up dosing, and we're using preemptive tocilizumab. And with preemptive toci, we've reduced any CRS rate from 70% across all of these, I think perhaps a little bit lower with Linvo to about 20% or lower, and most of that's grade 1. So I think that's our strategy, and it's worked pretty well.
Great. And then last question, Karina, about infection mitigation strategies. We know that these agents can lead to higher incidence of infection. What's your strategy in terms of mitigating infection?
Yeah, I think the BCMA bispecific is probably a little bit more than the GPRC5D, but for both, we give IVIG every month. We, VZV, PJP prophylaxis, and I keep doing it because especially when they're relapsing off of these, that's when the bad infections happen. So you can't stop.
Great points. I think one of the key advantages of bispecific T-cell antibodies in general is that they're really showing unprecedented efficacy for an off-the-shelf agent in patients in immediate need of therapy. And so I think these are particularly relevant in patients with rapidly progressing disease, kind of highlighting the initial 2 patient cases we just discussed. And there are some general considerations that you can consider. So there is clear data that shows that BCMA and GPRC5D bispecific T-cell antibodies are active in the post-BCMA CAR-T setting. However, the duration of response may be shorter when retreating with the BCMA T-cell engager after BCMA CAR-T compared to those that are BCMA naive. And certainly after progression on a BCMA bispecific, it'd be prudent to switch to a different mechanism of action or a different target. And in terms of GPRC5D target therapy, certainly you can use them in the post-BCMA space, but you can also use them in BCMA naive patients. And I think you saw great data that Karina showed about talquetamab bridging therapy in patients naive to BCMA therapy, and also it's a viable treatment option in non-CAR-T therapy patients. And so in the current NCCN guidelines, the recommendation for the incorporation of bispecific T-cell antibodies is in late-line myeloma, in alignment with the current FDA label in patients with at least 4 prior lines of therapy who are triple-class exposed. And currently we have 3 FDA-approved BCMA bispecific T-cell antibodies, teclistamab, elranatamab, and linvoseltamab, and we have 1 GPRC5D-approved bispecific T-cell antibody called talquetamab. And the approvals of these agents were based on pivotal phase 2 studies that looked at these agents in heavily pretreated relapsed refractory multiple myeloma. And this slide really summarizes the efficacy from these trials. And in summary, again, all of these agents showed unprecedented efficacy for an off-the-shelf agent in heavily pretreated relapsed refractory myeloma with response range ranging from 60 to 70%. Not only did you see really high response rates, but most patients had a very deep response, either a VGPR or complete response, and the responses were quite durable for this heavily pretreated patient population, usually lasting at least a year or longer. And so one of the aspects when administering these therapies is this concept of step-up dosing. And so essentially, we don't give the target dose right away, but we actually gradually ease the patient into the dosing by starting with a small dose initially, intermediate dose with a second dose, and a target dose with a third dose, invariably with all the approved bispecific T-cell antibodies. And this is really to mitigate the risk for high-grade CRS. And how step-up dosing is administered is slightly different between the different agents. For instance, with teclistamab here, step-up dosing is typically given on days 1, 4, and 7 with some window between the days 4 and 7 dosing. It's then given weekly thereafter, and at least per the package insert. Then if a patient achieves a CR for at least 6 months, then you can de-escalate to every other week dosing. However, I'll say in the real world, and I think all of us de-escalate the frequency dosing much more rapidly than what the package insert might suggest, just because we see very rapid responses with bispecific T-cell antibodies in general. I think the other thing to keep in mind is that if CRS is going to occur, it's going to occur during the step-up dosing period, and consequently, there is a recommendation for a hospitalization period after the initial step-up dosing. In the case of teclistamab, 48 hours after the initial first 3 step-up doses. As you hear from Sagar, there's a lot of interest and adoption of outpatient step-up dosing. We'll talk a little bit about that later on, how we can actually operationalize this practically to improve access to these agents for our patients. Elranatamab is very similar, has step-up dosing, 3 doses essentially, or 2 step-up doses before the 3rd target dose of 76 milligrams. Also has hospitalization requirements, a little bit less hospitalization per the package insert than teclistamab, 40 hours after dose number 1, 24 hours after dose number 2, and all outpatient thereafter. And again, there is a de-escalation of the frequency of dosing as per the package insert down to every 4 weeks after a year of dosing. But again, in practice, we often de-escalate the frequency of dosing much more rapidly just because these patients do attain responses quite quickly, and we can actually mitigate risks for infections and things like that by decreasing the frequency of dosing. And then I did want to mention remestemcel-l. Remestemcel-l is the newest BCMA bispecific antibody approved by the FDA in July of 2025. It has a slightly, perhaps different step-up dosing schedule. It's more spread out. So you have a step-up dosing, 5 milligrams on week 1, day 1, 25 milligrams on week 2, day 1, and the target dose on week 3, day 1 of 200 milligrams with a pretty rapid de-escalation of the frequency of dosing that was studied prospectively in the Linker MM1 study. So every 4-week dosing starting cycle number 6. And you can see that there's a little shorter hospitalization, 24 hours after the initial first 2 step-up doses as per the package insert. I think one of the reasons that this is the case is that remestemcel is actually administered intravenously. And so I think there's advantages and disadvantages of IV versus subcutaneous administration. Certainly with giving a subcutaneous administration, it's easier to administer. You have to have an IV inserted to actually give the drug. Patients are probably in and out quicker. On the other hand, with intravenous bispecifics, the onset and resolution of CRS is typically much quicker within 24 hours versus subcutaneous bispecifics, the onset and resolution within 40 hours. You can get patients in and out quickly in the CRS sort of risk period with IV bispecifics. So there could be potential advantages of IV bispecifics during the step dosing period. And then finally, talquetamab is a GPRC5D bispecific T-cell antibody. Again, incorporate step-up dosing depending on the final target dose and schedule. Can have either 3 or 4 step-up doses. I think most of us use the 0.8 mg per kg every other week dosing. And then again, per the package, a patient should be hospitalized for 40 hours after the initial first 4 doses. But again, there's a lot of interest in doing alternative strategies or step-up dosing. And I think, generally speaking, the inpatient hospital has posed a barrier to the sort of widespread adoption of these highly effective therapies and broad different community practices. We'll talk about, again, some of the strategies and how we can potentially operationalize this in the outpatient setting. And so going back to the initial 2 cases that we discussed, we had Anne who had high-risk myeloma. She's had 4 prior lines of therapy, BCMA naive or rapidly progressing disease. In this particular case, the BCMA bispecific T-cell probably would be the best option given the fact that it's off-the-shelf, can be immediately given to the patient. And we have Tom, who is now progressing with a very short duration response after 4th-line BCMA CAR-T therapy. And a GPRC5D targeted therapy would make a lot of sense in this context. I think it's important to counsel patients when giving talquetamab. There is this on-target off-tumor adverse event primarily affecting the skin, nails, and taste. And so just to advise and counsel patients what to expect so they're not caught off guard by some of these toxicities. So the next part of this session, we'll talk about what are some of the practical tools for operationalizing the administration of bispecific antibodies in our clinical practices. And so, one of the treatment emergent adverse events that's very common with the administration of bispecific antibodies is the risk for CRS. So this is the CRS data for the pivotal registrational studies for the 4 approved bispecific T-cell antibodies. And you can see that the incidence of CRS is common. So most patients experience CRS, mostly grade 1, which is just a fever. So I really want to emphasize grade 1 CRS is just a fever. Some grade 2, and really exceedingly rarely any grade 3 or grade 4 CRS. But this is something definitely that you need to be mindful of. And so consequently, the step-up dosing is incorporated, and then there's monitoring that's recommended in the hospital for step-up dosing period for these agents. And so there's been a lot of interest of what can we do to mitigate the risk for CRS, particularly during the step-up dosing, to potentially enable the outpatient step-up dosing for patients to then allow greater access to these agents for our patients. And many groups have looked at different models of administering these agents. And one approach has been the use of prophylactic tocilizumab prior to the first step-up dose. And this is actually data from the OPTIC study. So this is a phase 2 prospective study being led by one of my colleagues at Sarah Cannon and Peter Forsberg. That's basically looking at giving an initial prophylactic dose of tocilizumab prior to the first step-up dose of teclistamab, and with all outpatient step-up dosing. And this is being done at all community practices across the Sarah Cannon network. And the latest data was just presented at the SOHO meeting in Houston in September. So far, 24 patients have been dosed so far, only 2 cases of CRS, both grade 1, so less than 10% incidence of CRS. So it really shows that outpatient step-up dosing can be operationalized safely in the community oncology practice setting with prophylactic tocilizumab. And actually, prophylactic tocilizumab is actually now in the NCCN guidelines as of April 2025 as a consideration prior to the first step of dose to mitigate, again, the risk for CRS. The other thing to really keep in mind is the risk for infections. So definitely there's an increased risk for infections with bispecific T-cell antibodies, more so with BCMA than GP or C5d. If you do have some lead time, it's good to try to vaccinate patients prior to administering the bispecific, as the vaccine response will be blunted once the patient is on the bispecific. I do recommend baseline viral testing, so check hepatitis B serologies. If hepatitis B seropositive, then give entecavir as prophylaxis. I think the role of CMV monitoring is a bit of a gray area, but I still check it at baseline. It doesn't necessarily preclude starting a patient on a bispecific if they're CMV positive, but again, it will allow perhaps monitoring and preemptive treatment if a patient gets to a certain level. And PJP prophylaxis and varicella prophylaxis is mandatory in patients receiving bispecifics, particularly BCMA targeting bispecifics. Another really important component of the infection mitigation strategy is the incorporation of IVIG as primary prophylaxis. So don't wait for an infection to occur, then give IVIG, give it as primary prophylaxis. And there's clear data from multiple studies that this does significantly mitigate the risk for grade 3 or higher infections. There's a couple ways people do this. Some people give it monthly regardless of IgG levels. Some people check IgG levels monthly, and if it drops to less than 400 or 500, give a dose of IVIG. I think there's now the field is moving towards giving IVIG regardless of IgG levels, again, to mitigate the risk for infections. And so as you consider operationalizing, particularly the step-up dosing period for bispecific T-cell antibody administration in your practice, it's really important to involve the key stakeholders at your practice. So this include, of course, the physicians, the nurse practitioners, social workers, pharmacists, nurses. So again, these are all important components of the healthcare team. And so, really kind of walking through the patient journey. So as a patient, you see a patient in clinics. Well, which patients might be eligible for step-up dose? I recently went through this myself at my new practice in Nashville, where we had to walk through the patient journey. Which patients are candidates? So, certainly patients must be reliable, have a reliable caregiver during the step-up dosing period, be within a certain proximity to the treating center, we say within 60 minutes. So these are sort of non-negotiable things that we have in our practice. If a patient doesn't have these things, they should get inpatient step-up dosing. There's certain disease characteristics. A patient has high disease burden, maybe more frail, that could be at risk for more complications. Those are patients who may want to do inpatient step-up dosing. And of course, patient education, caregiver training, having clear protocols for monitoring during the step-up dosing phase if you do it outpatient, giving clear instructions to the patient if they were to have signs or symptoms of CRS, where do they go? Who do they call? That's very, very important. And then if they do develop CRS, what do you do? And so what's the protocol for administering either tocilizumab or dexamethasone in that context? And so just an example, the nurse is probably going to get the first call at most practices about if a patient has some adverse event, they're going to triage the patient. And so it's just really important, again, if a patient has mild symptoms, they could be followed at home still. If they have more urgent adverse events like difficulty breathing, hypotension, high fevers, those patients need to come immediately to the hospital for evaluation. So again, this really highlights the importance of educating different components of the care team. So in the last part of this session, I did want to talk about what's next in off-the-shelf immunotherapy with bispecific and even trispecific antibodies. We're seeing a lot of really exciting data at this year's ASH looking at bispecific combination therapy, earlier use even in newly diagnosed patients, and multi-antigen targeting. So I think one of the most exciting abstracts actually was just released a couple weeks ago. This is a late-breaking abstract of the Majestic 3 trial. This is really going to be a practice-changing study. And so this study evaluated patients with earlier relapse refractory multiple 1 to 3 lines of prior therapy with exposure to the PI and lenalidomide, and randomized patients either received teclistamab, daratumumab, or standard care triple with daratumumab, pomalidomide, dexamethasone, or daratumumab, bortezomib, dexamethasone. And the first interim analysis will be presented as a late-breaking abstract on Tuesday morning. And in summary, the study did meet its primary endpoint quite dramatically with a very, very impressive hazard ratio of 0.17. You see the 36-month progression-free survival of 83% in the Tec-Dara arm. So this is really unprecedented and sort of more in line with what we're seeing with CAR-T therapy with CARTITUDE-4. We see that the measures of efficacy across all domains favor the Tec-Dara arm. And actually, there is an improvement in overall survival as a key secondary endpoint with combination Tec-Dara over standard care triplet. I did want to highlight that there is this infection signal seen here, 54% grade 3 higher infection, again, really highlighting the importance of infection mitigation strategies when giving these combinations CD38 BCMA. And then there's also data being presented with linvoseltamab, also in combination with anti-CD38 monoclonal antibodies with either daratumumab or isatuximab, showing this combination safe and effective in slightly heavier pretreated relapsed refractory myeloma patients that will be presented as a poster on Saturday. And then there's also some data with dual antigen targeting. So many of you are familiar with the ReDirect-1 study. This was the first study that combined two bispecific T-cell antibodies, in this case, teclistamab and talquetamab. And the phase 1b study, long-term follow-up will be reported as an oral abstract on Sunday. So at 3 years follow-up, we're seeing quite durable responses on all comers, with the median PFS actually that has not been reached at the 3-month median follow-up. And in patients, particularly with extramedullary disease, the median PFS was quite impressive, around 22 months with this long-term follow-up. And the phase 2 study, which focused solely on patients with extramedullary disease, which remains an unmet need in myeloma, will be presented, again, seeing very high over response rates and quite durable response, again, for a difficult to treat patient population with a 12-month PFS of approximately 56%. I think the next wave of antibodies really continues on the theme of dual antigen targeting. Remestemcel-l, formerly known as JNJ-5322, made quite a splash at this past year's ASCO and EHA meetings, with the first-in-human data first reported. This is a dual targeting trispecific T-cell antibody that targets novel epitopes of both BCMA and GPRC5D that are different than teclistamab and talquetamab, with a low affinity CD3 to hopefully mitigate the risk for CRS. And there's a few potential advantages of dual targeting to potentially mitigate the risk for antigen escape, and also hopefully providing more selective on-target, on-tumor binding of the drug to, again, reduce the potential impact of on-target, off-tumor adverse events that we see the skin, nail, and oral toxicities. And with, again, this is early data, but among 27 patients who are BCMA and GPRC5D naive, 100% over response rates, 100% MRD negative rates among patients who are MRD negative, and nearly all patients progression-free at the 12-month mark. So updated data will be presented as a poster on Sunday. And then we're seeing also data with cevostamab. So cevostamab targets FCHR5, which is a novel antigen different than BCMA and GPRC5D. It's been in clinical development for the last several years, and we've seen monotherapy activity, and now we're seeing data in combination with pomalidomide showing that this combination is safe and effective. Again, this will be presented as an oral abstract on Saturday with additional data with this combination. And then I think, what's probably the next, what's coming up with the use of these bispecific antibodies, and of course they're showing really unprecedented efficacy as an off-the-shelf agent and relapsed refractory multiple myeloma. So naturally, we're going to be looking at these agents in newly diagnosed myeloma. I think one of the most exciting abstracts also at this year's ASH is being presented by Solomon Munir. It's a phase 2 study, the IFM 2021 study, looking at daratumumab, teclistamab, and newly diagnosed transplant-ineligible multiple myeloma patients. These are mostly, frail patients over the age of 70. 37 patients have been dosed so far. And what's very, very impressive is among patients who are MRD evaluable at essentially 10 to the minus 6, you see 100% MRD negative rate. So this is aligned really with what we saw with a Majestic 5 study, seeing 100% MRD negative rates at 10 to the minus 6. So pretty much these BCMA bispecific combinations are showing unprecedented efficacy in newly diagnosed myeloma patients. And then the other question is, if you don't give it up front, could you potentially give it as consolidation? And there's another very interesting study called the Immunoplant study. This is being conducted at the University of Miami. So basically in this study, patients with newly diagnosed myeloma received at least 4 cycles of some standard induction therapy that were MRD positive, at least achieved at least a VGPR. Then were enrolled on linvoseltamab consolidation for 4 to 6 cycles. And basically, you saw 100% MRD negative rate at 10 to the minus 6. So whether you get Eason bispecific up front in the beginning or as part of consolidation, the bottom line is pretty much you get 100% MRD negative rate at 10 to the minus 6. So I think the other thing that was really, really interesting is that if you look at the rate of CRS ICANS, 0% incidence of CRS. So for this particular study, prophylactic tocilizumab was incorporated, but you can imagine a scenario where in the community, a patient gets a standard quadruple-based induction regimen. Basically, any doctor can basically give a BCMA bispecific as consolidation with no risk for CRS with outpatient step-up dosing. So again, this I think is potentially, down the road we need more data, but a practice-changing approach to how we consider consolidation. And so, I really want to emphasize that BCMA bispecifics and GPRC5D and bispecifics in general are going to be here to stay. They're going to be forming the backbone of myeloma therapy for relapsed refractory myeloma patients, for newly diagnosed patients as part of induction, as part of consolidation. So if you haven't started giving these agents in your clinic, now's the time to do so. So with that, I'll close and hand it over to Sagar.
All right. Thank you. All right, everybody. Thank you. That was a great discussion. We've got just about 11 minutes to do some live Q&A. So I'll start off with one. Can we say we finally have functional cure in myeloma patients with all of our treatment options?
So I'll start. I think, what is your definition of cure? And so, mine is off therapy. And again, functional cure 5 years out without any treatment. And I think, again, relapse refractory, we were always wishing we had what lymphoma had. And now at least one study shows that. But what I said earlier, I am very careful about saying that to my patients, that yes, this is amazing. Time off therapy is fantastic. And I want that for everybody. But I still need to watch that myeloma. It's not, you're gone and you're never going to have to come back to me and I'm not going to have to treat again. So sequencing's still a big discussion of, what do I do after that CAR T for patients? Yep. I don't know what you think about the bispecifics.
Yeah, I think the long-term follow-up of CAR-T1 is very provocative. I think that's a signal of maybe a functional cure. And I think time will tell. We're seeing these unprecedented MRD negative rates with bispecific combinations frontline. And will some of these patients be cured long-term? We'll just have to wait and see. But I think the early signals are very, very encouraging and promising.
Yeah, I mean, I think it's a good sign that the IMS and the IMWG is actually going to define what cure means in myeloma. I think there's a manuscript that's coming, and there's a meeting planned for the spring, I believe, to really try and talk through what that is now. I've got patients that are 15 years post-transplant and have never been on other therapy. Some are on maintenance, some are not on maintenance, and I would argue they're functionally cured. I think in myeloma, even if you go back to the Arkansas data, there was always a plateau at about 10 years of somewhere between 10 and 20%, depending upon how you look at it. And so I think we've had that plateau. The question is, can you increase the number of patients? And I think that's what these options really give us the opportunity to do, to increase those options. Okay, so have you ever used BCMA or GPRC5D bispecific as a bridge to a CAR T, and for which patients? So this sort of harkens back to one of the cases in your talk.
Yes, I think those patients who are really relapse refractory, it makes the most sense. Now, eventually, when we hopefully get combinations in earlier lines, that will be great to see those too. But yeah, right now it's the late line patients that are already penta-exposed. Carfilzomib's been used. It's a lot easier to give them the talquetamab. We were using BCMA when we didn't have the GPRC5D, but I think now, without knowing the sequencing and what happens to the antigen before you give those cells, we like to use a different target for sure.
Yeah, okay. And then there is a question here about how long can manufactured CAR T cells be stored before being used? Do they expire?
So that's a great question, because in standard of care, unlike clinical trials where we usually, have only a certain amount of time for bridging and you can only use certain drugs, in the standard of care world, thankfully, I've all my patients have made it to cells because, again, I can switch bridging. So most cells are good for 9 months to a year. So again, I don't have to give them right when they're ready. I can actually make sure that patient's doing really well before they come back for their cells.
I don't know that they actually expire, though, because I think they're like stem cells. They're stored in DMSO. And so there's an insurance expiration, but I don't know that the cells themselves go bad. But
we've had to recollect people if they went 9 months. So I think that in terms of actually logistically giving it, that 9 month period is sort of what they say.
Good. All right, we've got another one here. Have any patients relapsed late post-CAR T despite sustained MRD negativity for a period of time?
Yeah, absolutely. I think, the CAR-T4 data CAR-T1 data long-term follow-up is encouraging, but I think we have to remain vigilant. I think we've all had patients with late relapse myeloma. So again, time will tell. Some of these patients have very long-term durable responses, but they can still relapse.
I mean, even if you go to CART1, the median PFS was 36. The plateau we're seeing is at 5, and there's a delta between that, and those patients presumably were MRD negative. Mm-hmm. The MRD positive probably relapsed within the first 18 months. So unfortunately, it's still there. And so, I think an important message is achieving MRD negativity is a step towards the cure. It is a requirement if you want to talk about functional cure. but it doesn't mean you're there. And to me, sustained MRD at year 2 and year 3 are probably the really important predictive markers of who's going to be potentially on that plateau. I've got one for you guys. So let's say that with a Majestic 3, you get Tech DARA approved early, you've got Cilta-cel potentially early, and you've got Bella potentially early. Just give me some thought processes. I'm not going to ask you, what would you do? Because that's not fair. But give me some thought processes about how you might think about using those 3 different options for a given patient you might see.
Yeah, I think, sorry you stated earlier on that, there's multiple paths. And so I think the great thing is we have 3 great modalities for patients in this particular context. And so I think it really comes down to the patient discussion about what they value. I think, CAR-T is a great option, particularly for that time off therapy and that quality of life. On the other hand, bispecific antibodies logistically are easier to administer with great responses. And I think, there will be a paradigm shift. So right now, the current paradigm is to give bispecific antibodies continuously until progression, right? But, probably fixed duration is the way to go, where it's not just a one and done with CAR-T and continuous forever for bispecifics, but probably one and several with bispecifics. And of course, Bella is a great option for patients not candidate for either as well, or who want a simpler option as well.
Yeah, I agree. I think the idea of multiple myeloma is multiple, right? I mean, all my patients are very different that are coming into clinic. At least with CAR-Ts now, the FDA doesn't require 4 weeks or 8 weeks of no driving. All that has actually improved, which is supposed to improve access. Again, it depends on when the CAR-T, the expansion happens. So again, most of my patients do still stay with me till 3 weeks. So it is a huge ask for people to come to, major centers for that. Not everybody can do that and have a caregiver the whole time. So I think bispecifics are fantastic, but I agree. I think it needs to be fixed duration. That's sort of my ask is hopefully even in late line and single agent, most of my patients don't continue forever because again, infections, they don't respond to vaccines. There's a lot of things we're doing to the immune system over long term. So I think they're fantastic, but maybe once we get to MRD, can we really spread it out and maybe even stop for some of those patients? So that'll be really great. And if patients need a CAR-T later, their T cells will be better for later. So I think those questions really are still important. And then the Bella, I think a lot of my patients who live far away and just don't want to be in the hospital at all, don't want that, have had major infections. So we've had a lot of frail patients that have infections even when they're smoldering, right? That those patients, I really don't want to push through all of that. And Bella is a fantastic option to use there.
Yeah, no, I think you guys have nicely sort of dissected out what potential paths might be for different patients. So is there a rationale for maintenance therapy following successful MRD negative CAR-T?
Great question.
I'll let you answer that.
Yeah, so I think this is where the high risk versus, standard risk patients. So again, the one and done is amazing. We want that for our patients. But my high-risk patients tend to relapse earlier. And we have some translational data of whose T cells are really good and they do well long-term. So the question is, can we do something before apheresis that makes those T cells and make that better response, or after, right? So again, better bridging works better. But I do think our high-risk patients, especially those that don't have MRD undetectability in the first 3 months, or even at their MRD positive a year later, those are the patients we probably should be doing some type of maintenance to make sure they get the long-term efficacy.
Yeah, I know I'm probably out of the normal distribution on this, but I actually give a little bit of IMiD maintenance to every patient post-CAR between months 3 and 12. And that's it. Then I stop at month 12.
Yeah.
And the goal here is to try and propagate and improve persistence. Many have told me, well, the CAR's already gone by that time, which may be true. It's hard to know, but I actually think there is value. And our PFS at like 2 years is well over 85% for a lot of our CARs. So whether or not it makes a difference, I think is hard to know. But to me, ultimately, if you have a choice, switching the target in maintenance actually makes a lot of sense. So if you're giving a BCMA CAR, thinking about something GPRC5D as a maintenance strategy, particularly in that high-risk group, makes sense to me.
Yeah, as I mentioned, Adam Cohen has a very nice study of doing Cevostamab post-CAR-T, showing very high MRD negative rates at over 90%, 10 to minus 6. So again, I think these strategies are definitely potential options.
Okay, so there's another question. We got a couple more minutes. Have the newer treatments tempered your enthusiasm for transplant in myeloma?
Okay, so as a recovering transplanter, so I used to be a transplanter when I first.
You want the old guard to go first, or you want the young kids to go first?
Right, maybe you go first.
I know your thoughts.
I know. Might have some opposing thoughts here.
Go ahead, Hans.
Yeah. So I think certainly, I think we're seeing very high MRD negative rates. There's a recent study called the MIDAS study published earlier this year, which basically showed that there's really no incremental improvement of depth of responses or MRD negativity with autologous transplant. And so I think particularly in standard risk myeloma patients, I may consider deferring transplant if a patient is standard risk after a discussion. On the other hand, the Perseus data is very strong. You see that sort of program of DARA-VRD, transplant, consolidation, maintenance, showing, probably median PFS of 17 years. So that's hard to argue. So I think Sagar's mentioned MRD is a prerequisite probably to attain a goal, but it doesn't necessarily say that you're going to make or attain that goal because, again, it doesn't necessarily correlate with PFS all the time.
Yeah, and I would sort of say before the availability of DARA as part of our induction, the relapse rate per year was roughly 8% per year with RVD transplant and lenalidomide maintenance. With DARA, that's cut to 4% per year. So I think that's a pretty high bar. It wouldn't surprise me if something were able to beat it, but they need to prove it. I think, MRD as a surrogate is nice for FDA approvals. I don't know that it's nice enough to change practice. That'd be my answer. All right, I think we've got time for one more. So many BCMA-directed immunotherapies are available. Do you think we should be checking BCMA expression frequently to detect antigen escape? Quick answer.
So I think we have soluble BCMA, we have sequencing, and then we have staining. And so not everybody has all those. I think you need all of them. And I do think we need sequencing because, again, some of the resistant mechanisms isn't loss. It's actually mutations. So, yes, we need all of the above.
Yeah, I think we're going to have to come to a point where we're doing sequence like BCR-ABL kinase domain mutations. Same with BCMA.
Yeah. All right. I think with that, we will wrap up. Thank you to our audience, both here and online. Thank you to my colleagues for a great presentation and great discussion. Have a wonderful ASH, and thank you for joining us this morning.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, the HealthTree Foundation for Multiple Myeloma. This educational activity is supported by independent medical education grants from Arcellx Incorporated and Kite, a Gilead company, GSK, Johnson & Johnson, and Regeneron Pharmaceuticals Incorporated. To access all materials for this activity, visit peerview.com/JGX860.